Well, welcome to the Aging Boomers. I'm your host, Frank Sampson. Of course, on our show, we discuss so many of the issues facing boomers, their parents, whom we know, of course, is an aging population. Of course, I'm part of that. And just to let you know that today's show is sponsored by Senior Care Authority, a professional senior placement and elder care consulting organization that has a national network of advisors to help in determining the right path for senior living and receiving proper care. So whether you just need an advocate or you need assistance with in-home care, assisted living, or residential memory care, get the necessary advice from a senior care advisor in your area by calling Senior Care Authority at 888-809-1231, or you could go directly to the website at seniorcareauthority.com. Again, want to thank everybody for all their support with the show. Our lists are growing every day. Tens of thousands of listeners now, so we're looking to get to that 100,000 mark pretty soon. Just get the word out. You can certainly, many of you get up to date on the show by downloading the free app on your iPhone, Android phone, iPad, etc. Just type in the Aging Boomers, and you could keep up to date on all of our shows and the great people that we interview. Also want to thank you for your support on my recent book called The Aging Boomers, compilation of some of the interviews we've done in the past. So thank you for that. And speaking of books, we have a wonderful guest today that's extremely knowledgeable. His name is Dr. Josh Luke. He is the author of a book that recently came out called Ex Acute. A former hospital CEO tells all about what's wrong with American healthcare. He's also authored a book called Readmission Prevention, Solutions Across the Provider Continuum. Dr. Luke is part of the adjunct faculty, University of Southern California, Sol Price School of Public Policy, founder of the National Readmission Prevention Collaborative and National Bundle Payment Collaborative. Dr. Luke is a best-selling author, healthcare futurist, thought leader, and international motivational speaker. He is an experienced hospital CEO, health system vice president, and nursing home administrator. He's regarded as a futurist on the Affordable Care Act, some call it the Obamacare, and how it will shape the continuum of care. He currently serves as a chief strategy officer for Nelson Hardiman Healthcare Law and its subsidiary consulting firm, Compliagent. So, Josh, welcome to the Aging Boomers. Thanks for joining us.
Yeah, I'm happy to be here, Frank. Thanks so much for having me. Perhaps the greatest credential I have beyond what you just mentioned, and thanks for that introduction, is that I'm a caretaker for my aging boomer parents as well that are in their early 70s, and unfortunately my mom suffers from Alzheimer's disease and is now stage 6, and I've been on this journey with them, and so from both a professional and personal standpoint, that's been able to shape my career and who I am and the perspectives I have. So thanks for having me, and hopefully I can share some valuable input with your listeners.
Well, as you know, you and I have met and have talked several occasions. I know you're going to provide our audience with some valuable information. I thought we'd start out, Josh, just maybe giving our listeners, try to get them up to date a little bit on kind of what's gone on with the healthcare system over the past, I don't know, again, you go back a couple decades, but that could take a day to talk about, but maybe you could just recap it for us and bring us up to date of where we are today.
Sure. I was blessed to become a hospital CEO at age 32, and before that I was running nursing homes, and the industry that I entered in the 90s was an industry that was reimbursed in what we call fee-for-service. We don't need to dig any deeper on that name than that, but the name actually describes the methodology well. If you called your doctor and said, "Doc, I'm not feeling good," he or she only got paid if you went to the office and they could bill the federal government for that visit. And the hospital that they worked with help support them, only gets paid if you get admitted to the hospital. or visit the emergency for providing. And the Affordable Care Act, which is the Affordable Care Act passed, the goal was to create a patient-centered model that focuses more on the patient and good health, what I call healthy lifestyles and wellness, and to disincentivize hospitals and doctors from prescribing unnecessary care. And in the industry, we have a term we call overutilization, which is really, in a sense, overprescribing things that may not be necessary. And what that fee-for-service model did was, in many ways, incentivize doctors and hospitals not to ask a lot of questions when you called, but just to say, oh, you need this, we're going to run this test, we're going to run that test, because the more tests they ran, the more they were able to bill. Then the Affordable Care Act came along in large part because just like each of us have a bank account, when it starts to run dry, we start to scrutinize each of our expenses. The federal government started looking at the money in the Medicare fund and said, hey, we're starting to run dry here, and it's not going to last much longer, and we need to be a little more careful about what we pay for and what we don't. So let's ask these doctors and hospitals to do a little bit better documentation on what they prescribe. Let's give them some criteria and say you can only prescribe these things under certain situations. And the criteria is really what changed significantly. And there was just an article that came out in mid-June that said the newest projection of the Medicare fund running dry is now 2028. While that might be good news for a lot of you, it's not good news for me because I won't qualify for my benefits till about 10 years after that. So in any case, that's just a basic description of what's changed. Now, the Affordable Care Act has significant penalties for doctors and hospitals who overutilize and admit patients to the hospital or have you come to the doctor's office or emergency department unnecessarily. So it's really an attempt to get to patient-centered care where it focuses more on your health.
So I'm going to put you on the spot, especially we're in a political election year. Do you think it's a good thing or a bad thing, the Affordable Care Act?
Well, that's a slippery slope. Overall, the patient wins in terms of health. Does the patient win in terms of their pocketbook? There hasn't been a lot of evidence to prove that at present. And as you mentioned a few minutes ago, I have a brand new book out, and there's a chapter 14. The new book is available on Amazon.com. It's called Ex-Acute, a former hospital CEO tells all on what's wrong with American healthcare. And that's EX-acute, execute like execute hospital CEO. And chapter 14 is called A Lesson in Capitalism, Why Your Family's Healthcare Costs Will Continue to Increase. And really the chapter, the nice thing about this book too is it's what I call a coffee table book. It's 150 pages, but some of the chapters are just 2 or 3 pages long, so you can kind of sneak them in when you just have a 5-minute break. But that chapter just says, hey, this is a capitalistic society. Hospitals and insurers are publicly traded in many cases. They have to continue to show a profit, and their expenses are going up. You have entrepreneurs that are providing solutions that they need to make a buck to cover their costs, and all of those expenses are being passed on to the consumer. And unfortunately, that's true even with Medicare participants and Medicare recipients. So is the Affordable Care Act a good thing? Financially, it's likely going to cost the consumer more, at least for the short term. I do think there will be a savings in the long term, but we're talking about at least 5 years before we hit the top of the curve and start to work our way back down, because this transition has been a massive transition.
We're hearing, and it just came out in the press the other day, about a number of doctors and others being arrested and just because of Medicare fraud. And how big of a factor is that in this whole process?
Well, fraud is an awful thing, and certainly part of how President Obama justified passing the Affordable Care Act was taking back, we call it a clawback. In politics, they call it a clawback, dollars that were already spent for those who are committing fraud. And unfortunately, the Medicare system and the prior methodology did not require a lot of documentation. And so what they've done now with the fraud investigations is gone out and they've found those bad apples. And there's really 2 kinds of bad apples that are being prosecuted. One is just the criminal who's doing committing fraud with intent and taking advantage of a system that did not have a lot of checks and balances and was a massive system, being the Medicare system. And those folks, shame on them, and good for the federal government for going after them. The second group that falls into that category are practitioners, whether hospitals, nursing homes, doctors, providers of durable medical equipment like wheelchairs and other things, that have not conformed to what the federal government asked them to do in the last 15 years or so, which is to provide decent, efficient documentation to prove that what's being prescribed is needed. So when it's paid for, there's documentation to back it up. And those folks are being grouped in with the others and being arrested and prosecuted, and shame on them for not conforming. So there's a lot of fraud arrests taking place. You're going to see those continue to grow. They will recapture a lot of dollars, but unfortunately, I don't think those dollars are going to trickle down to into savings for the consumer. And if they do, it'll be probably 5 to 10 years before we see that happen.
Yeah. So there seems to be, with the Affordable Care Act, there's a lot more pressure on the hospitals and on the doctors to get things done right the first time. Is that correct?
No doubt about that. One thing that I think is important for everyone to understand, every boomer to understand that is a Medicare recipient, is your mailbox is getting filled up during open enrollment with what are called Medicare Advantage plans. MA plans is the term we use in the industry. And folks like Frank and I that work in the industry get asked all the time by boomers, hey, should I stick with my straight Medicare fee-for-service, or should I sign up for an MA plan? And the answer to that is different for everyone. The benefits that I see for Medicare fee-for-service, if you just keep straight Medicare, then you can go to any doctor you want anytime you want. You don't need pre-authorization for a lot of things. It's just the old-school approach. And in large part, the federal government is trying to do away with that, but it's going to be a couple more years before that happens. The Medicare Advantage plans, the nice thing about that is, and again, remember, I'm a caretaker caring for my aging parents who live just a couple blocks away, is when you have a question about your health, there's plenty of people in your MA plan you can call and get answers to. They may limit the doctors that are participating, but usually you can find a good doctor in there. But more importantly, if you're focused on your health and your specific needs, each of those MA plans caters to different things that might attract you. Some, for example, might not have a copay for your pharmaceuticals. Others may have $1 or $5 copay, but might provide a little limited dental benefit. So it's really about doing your research and doing your homework. And the Affordable Care Act has introduced another new program called Accountable Care Organization, an ACO. You may hear a little bit about this. You don't really need to research it too much other than to know your doctor signed up for it. And now it's another form of, it's not called Medicare Advantage, but it's really very similar. There's now a group of people working together to manage your care, and you will eventually be able to have someone you can call to answer your questions in advance or after the fact. And again, the ACO is the government's effort to get rid of fee-for-service Medicare, because there are very few checks and balances, and to move to a model that's much more like Medicare Advantage, where somebody is responsible for your care and they get penalized financially, not the federal government, if you're being overprescribed for different services.
So what can the consumer, or many of our listeners, expect? I mean, if they do have to go to the hospital, let's just say they have an elderly parent, they've unfortunately maybe broke a hip, had a fall, they go in for surgery. How are things going to be different for that person today than maybe they were in the past?
Well, great question, Frank. There's three answers to that question. The hospital is not going to get paid if they admit you and don't have justification for it. So that's leading to a new trend of discharging you home or to a post-acute facility directly from the emergency department. What it's done is it's encouraged good behavior from the hospitals, which is to ask you more questions. In the past, if they asked you more questions, they may find out that they didn't need to admit you and couldn't run a bunch of tests and bill for them. So now they're asking more questions, and they're accessing the electronic medical record. And although that's been a snail's pace of an implementation, the hospital may have a little bit of a medical history on you if you consent to let them look at it, and can use that to better determine what your needs are. If those needs aren't acute, they'll discharge you home or discharge you to a post-acute facility if that's more appropriate. If you do get admitted to the hospital likely is going to keep you for a shorter amount of days than they have in the past. And let me give you a basic example of why. In large part, hospitals are now paid a bulk payment for your stay. For example, the government might say, here's $5,000 for this hospital stay. So if you stay 2 days, that averages out to $2,500 a day, which covers the hospital's per day cost. But if they ended up keeping you for 4 days, and now you're down to $1,250, I think if my math is correct, that does not cover the hospital's per day cost to care for a patient. $1,250 doesn't in most cases, in almost all cases, so they lose money. There's a term in the industry that would be great for you guys to remember. It's an easy cliche. It's called right care, right place, right time. And really, when you think about the new model, that's what you can think about. And a lot of people might find it a little frustrating because in the past you were able to stay, and sometimes people feel more comfortable in a hospital. But really, that was the result of bad habits of the delivery providers, the doctors and hospitals. So right care, right place, right time is going to become more common. And when you do go to a post-acute facility, there's certain higher, more expensive levels of post-acute care that look like hospitals or for aggressive acute rehab that are in large part going to be not utilized as much, and they're going to start to use skilled nursing facilities, which are convalescent homes, as an alternative because it's much more affordable for you. And on that term of convalescent home, you might say, well, I haven't heard that term in a while. And there's a reason for that, because there's nobody in America that looks forward to the day that they have to go to a convalescent home. Nowadays, they call them skilled nursing facilities or rehab. Again, just referring to my new book, Execute, there's 2 chapters, Chapter 20 and Chapter 21, called Caring for Mom, Tips from the Trade on Caring for an Aging Parent and Selecting a Senior Facility. And Part 2 is Understanding the Different Levels of Care for Seniors. And it thoroughly describes each level of care from assisted living to skilled nursing to acute rehab. And it talks about how a lot of the skilled nursing facilities want you to think they're not a convalescent home or a nursing home. They are, in fact, exactly that. They've just changed the name because generationally, convalescent home and nursing home became a really unfavorable word. And so they had to generate a new term, and skilled nursing facility or rehab facility is what they use now. But let there be no doubt that even if you're going or being referred to a skilled nursing facility for just a week or 2 of rehab before you go home, when you get there, you will find that 80% of the residents, the patients there, are there for life because it is, in fact, a convalescent home as well.
So do you think that, you mentioned assisted living, so do you feel assisted living and memory care will play an even more important part in this whole navigation process than it did in the past?
No doubt about that. No doubt about that. And assisted livings, in large part, do almost as much as many skilled nursing facilities nowadays. The main difference, and I really think this is the one thing I would want folks to remember if, in fact, they're having to make a decision about institutionalizing a loved one or a spouse. Assisted living is private pay, meaning you're paying for it yourself. Skilled nursing, in most cases, is paid for by an insurance benefit. So when people say, do I have to go to a nursing home, it often comes down to a financial decision. And you can get almost all the clinical and therapeutic needs that you need cared for in an assisted living nowadays if you do your homework and do your proper research. And Frank, I heard you mention that one of the sponsors of this program is Senior Care Authority, and they're a perfect example of an organization that if you're faced with that decision, you can contact an individual from SCA or any other organization and say, hey, here's where we're at as a family, and we need to make this decision. Can you help us? Can you give us some examples of why one facility might be better than the other and why an assisted living facility might be more appropriate for our loved one than a skilled nursing facility? And I said it earlier, and people laugh, but it's not a joke. There's no American that wants to go to a skilled nursing facility. So whether it's a spouse, you as an individual, or a loved one, if a assisted living is an option, or even a residential care facility, which is also, in essence, an assisted living facility, is an option, and you have the finances and resources to do it, I think it's a great option. And Frank, I'll close that comment on this. I go to assisted livings a lot to either speak or visit or just help them strategize. I always joke with my wife. I go into many of these assisted livings, and gosh, I'm in my young 40s, and I say, man, I'm ready to move in here now. This place is immaculate. They got a little lounge for us to hang out at night with a private wine locker. They have activities all day long. I don't have to cook or clean. This is a great environment. So when that day comes for me, I'm just hopeful that I do have, the funds in the bank to pay for it, because, as I said, I'm like every other American. I hope to never spend a day in a skilled nursing facility. I certainly wouldn't want my beloved wife of almost 20 years now to have to suffer through that process as well.
I want to make sure we leave a little time to talk about your book, but you used a term with me before that I'd love you to, just talk a little bit about, which I think you have designated as the word of the year. Tell us more about that.
Okay, well, it's a LUPA, and this is some really heavy lifting for you listeners, but I'm gonna speak at a level that helps you understand, and it really is a great way to kind of wrap up this 30-minute session, Frank, because it is a perfect example of what's changed. LUPA is a reimbursement term in Medicare called a low utilization payment adjustment, and you don't really need to pay attention to that other than to know this. If you go home from the hospital after a hospital visit, or from a nursing home after being there for a week or two for therapy, and you're prescribed home health, after your fourth visit, the federal government reimburses about $100 a visit to the provider for the first four. But at the fifth visit, it rotates into a bulk payment of $3,500 for the remainder of the services they provide you. And those services usually last 6 to 8 weeks. So your 4 visits largely would make up probably 1.5 to 2 weeks, okay? After that, the remaining 4 to 6 weeks would be compensated in that $3,500 payment. What's happened is the government has incentivized hospitals to be part of the insurance company through this ACO we discussed. And again, this is heavy lifting, but what it's done is the hospital now is saying, after 4 visits, there is no way we're going to allow our beneficiary to have a 5th visit, because that's going to cost us an extra $2,000 when we can just have that patient go from home to an outpatient therapy center to continue their therapy. And in many cases, you're strong enough after just 2 or 3 visits to not need any more therapy. And so the LUPA is a way to describe how quickly, when hospitals were made aware that they're now being reimbursed based on your wellness and health and not on how much care they can provide to you, they quickly realized that they don't want to provide a 5th visit because it costs them an extra $2,000. And this is one example, Frank, of the larger trend that the Affordable Care Act has brought, which is what I call a discharge home mentality. And in the book Execute, we talk a lot about discharge home and how providers traditionally, because they were incentivized to send you to a nursing home so they could make more money, never even let you know when you were in the hospital that going home was an option. They told you you need to go to a skilled nursing facility, or we're going to transfer you over there is the word they used, instead of discharge you, so you knew you had an option. And what's changed now is they're letting you know that, hey, you can go home if you prefer, or go to a skilled nursing facility. And that also leads to the question of, well, and that's when you should feel empowered as an individual, a patient, or a family member to say, hey, doc, I heard that assisted livings provide just about as much therapy and clinical support as a SNF. SNF is a term for skilled nursing facility. So can I go to an assisted living? And the answer is usually going to be yes, but most of you will probably say, wow, my doctor's never engaged me in that conversation that I could go home or could go to assisted living. He or she just said, I'm transferring you over to a skilled nursing facility. So feel empowered, folks, to ask those questions. And that's probably the best thing you can get out of this discussion today, is feel empowered to ask questions, particularly if you're referred to a post-acute facility, to say, what are my options beyond that facility?
Great suggestion. tell us more about the book. We don't want to give it all away because we love our listeners to get it on Amazon, but tell us who you're really targeting, who's going to really benefit from getting and reading your book.
Thanks so much, Frank. The book, again, is called X-Acute, EX-Acute. It's available on Amazon, and I also have a website if you guys are interested and you like to surf the internet. It's called joshluke.org. And at joshluke.org, it talks a lot more about my background, and you can learn more about X-Acute. But let me give you a couple of chapter titles that may be of interest to the boomers, because this book was written really for every American who's interested in better understanding our healthcare delivery system. And as I wrote, I thought a lot about three different groups of individuals. The first is boomers. Actually, there are four different groups of individuals. The first is boomers. The second are those adult children that are caring for their aging parents like me that are largely probably Gen X. And there's actually a couple chapters specific to millennials and how the health system is going to be so different when it starts to become a priority for them. So those are three of the four groups that I really was thinking about as I wrote the group. And the fourth is just young parents. When your little one can't communicate with you because he or she doesn't talk yet, how do I ensure the best level of care for my little one? So I thought about those young parents that just want to make sure they know how to access care in a managed care environment, because 5 years from now, particularly for senior level of care, with the Medicare fee-for-service will largely be going away, and so everything will be managed care in a way. So a couple of chapters that might be of relevance to boomers are the two caring for mom chapters I talked about. For chapter 22, long-term care insurance, Medicare Advantage, ? How do I pay for my parents' care, ? That's the title of the chapter. Should I have long-term care insurance? What are the benefits? What about MA? We talked about that on this call. Chapter 23, I get asked this a lot. Single-payer system. Does the Affordable Care Act and Obamacare story end with a single-payer system? It might. I don't know the answer to that, but I go back and forth about where that may be likely. Should I check out a high-deductible insurance plan? Chapter 15. Chapter 16, how to save a few bucks when you access care, getting discounts from doctors and hospitals. I think everybody might be interested in that one. And just to wrap up, most of these chapters, guys, are from part 2. Part 1 of the book goes back to the first question Frank asked me. Hey, give us the history of how we got here from fee-for-service to the Affordable Care Act. Part 2 are all these chapters I'm sharing with you that are kind of a user's guide to accessing care. So the last chapter I'll share with you, chapter 17, how can my family utilize technology to increase access to quality health care and improve health? If you're interested in technology and reducing your healthcare expenses and getting into self-management, which I strongly encourage, there's a chapter for that as well. So that's X-Acute, and it's on Amazon.com.
Josh, you've exceeded my expectation. I knew it would be good, but it was great. Great information. Check out his book on Amazon. You could also, can I mention your website too, Josh?
Sure.
So joshluke.org. Just go to joshluke.org, and you can it's tough to keep up with Josh, but it will help you see everything that he's involved with. And but thank you so much for joining us. We're going to have you back again, I'm sure. And so thanks again. And
my pleasure. Anytime, Frank. I look forward to coming back on.
Great. And I want to thank everybody out there for tuning in to the Aging Boomers. Just be safe out there, and we'll talk to you all soon.